Good morning. I'm Dr. Robin Nelson. I am here to facilitate today, and it's truly a pleasure. I hope all of you had a very enjoyable and a sort of a brain stimulation day yesterday with our topics. We were so fortunate to have a wonderful group for day one of our nursing practice and healthcare. I love the combination because we wouldn't have healthcare were it not for nursing practice. I always tell my students, because I'm in academia, that they are the glue of healthcare. And so today we're going to continue this amazing journey to discuss nursing practice and healthcare. And we are going to have our spring conference in April 11 and 12 in Orlando. And that sounds like a great place. We hope Mickey is waiting for us there. And the focus we're going to be looking at is we're going to take a journey into the future of nursing. And I'm sure you're all have right at your hand here. Well, when I've got my background, I'm really not in the kitchen if you think that's rude. But anyway, I have the future of nursing recommendations, and I was reading through them, and it's really the emphasis is on a shared agenda for addressing social determinants of health and achieving health equity. And then it goes on, there's 9 recommendations. And they go on to talk about the implications in terms of supporting nurses' health and their well-being, also have more equity in pay, and they call out school nursing. And they, talking about, including nurses in the design, generating, analyzing, applying, all of the various avenues to bring about, and it keeps talking about health equity and health, the social determinants of health. So if you looked at what we heard yesterday, I mean, we had, talking about complex systems. How are we going to get our students, into the health workforce? Civility, and how that's so important in terms of the work setting, the relationships between, coping, negative thinking, life satisfaction, social support. We all have these, issues that we're dealing with. And then I sort of, facilitating clinical nursing education. And I like the new normal. Actually, I think by some people have said, it's the now normal. It is what we're, going to be dealing with from here on out. So it's, I'm sorry, I'm shutting down my my email as you hear, ding, 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 I apologize. Anyway, so with that being said, we're just going to continue on. And pardon me? I think somebody needs to mute themselves. Otherwise, we're going to be listening in on your conversation, which I'm sure would be very interesting. But we're ready to launch day 2. Thank you for being here with us. And it really, truly is a privilege for me to introduce our first presenter, Dr. Anita Girard. And I was talking to Anita because it was saying she's vice president and chief of nursing. Now, I'm a very visual person. I just had this vision of her having a beautiful headdress on as the chief of nursing, but she's technically the chief nursing officer at Cedars-Sinai Medical Center in Los Angeles. She's coming to us all the way from Washington, D.C. So I appreciate the fact that we're all over the United States and the world in terms of coming to this conference. I love her title too, because I think that extreme leadership, I'm very anxious to find out what is that going to be. And she calls it the next normal, not the new normal. And so Anita, I'm going to turn it over to you because I think we're going to be able to gather from your presentation your vast experience, your successful history of working in, in the service setting in the healthcare industry. And I think I would be remiss. She is the president of the American Nurses Association of California. And it's a privilege to be a member of ANAC and to be able to learn from Anita almost every day. Welcome, Anita.
Great, thank you, Robin. Can you hear me okay?
Yep.
Okay, perfect. Just want to get started. I am coming to you live from the American Academy of Nursing. So they're here in Washington, D.C. There's about 400 attendants in the real conference, and there's 400 virtually. So I'm sorry for the yellow effect. I'm in the hotel room, and this is the best I can do with the lighting situation. But really appreciate gathering again thought leaders from across the world. And thank you to the ResearchGate for hosting us. It's always an incredible learning session. I did call it extreme leadership because the last 18 months or more, the last 2 years have required just the kind of leadership that I've been in leadership. I've been a nurse for over 30 years and in leadership for greater than 10. And this has been the most trying time of my entire career. And I think for many nurse leaders and just nurses across the entire globe. I do think it is the next normal. It's not a new normal. We have to move on to blowing it up and thinking of it out of the box and something completely different than we've done before. What we have done in the past will no longer work in this next normal that we're about to create together, hopefully. So I just wanted to talk today with you all about that. I don't have any conflicts of interest. I'm hoping that we can take a look at the current state of nursing and healthcare. I think it's really important to where are we currently? Look at some skill sets. I really think it's important that we give our new leaders a toolkit for them to, we all have these great things that we've learned through our careers. And I kind of started putting them together as just a thought package of, wow, I like this one and that one, and I'm going to put them together in a bit of a toolkit today to talk to you about. So would love for it to be a little bit more interactive. Hopefully I'll finish in enough time that we can have some discussion because I want to learn from all of you as well. And then discuss what's next for nursing. And I'll present a case study from Cedars-Sinai. I'm the chief nursing officer, as Dr. Nelson said, at Cedars-Sinai in Los Angeles County. We were intensely hit by COVID over the past 2 years. We have about 1,000 beds. We actually have 889 licensed beds, and we today are over 1,000 beds. So we basically, I tell my nurses, have added a small hospital on top of our hospital to try to care for all the patients. And the community burden that's out there with all our heart attacks and strokes and people who haven't received care previously are coming to us now. So it's time to take a look at things. Just let's blow it up, let's put it back together, and let's figure it out together. I want to start first that this is one of my favorite slides. I've looked at it for years, but I like to kind of show it that despite everything that's going on, we still continue in the United States to spend more than other countries for our healthcare, and our GDP is much higher than other comparable countries on average. I found this great website called the Health Systems Tracker that had amazing data all put together. So I want to share a little bit of that with you today. Also that on average, other wealthy countries spend about half as much per person on healthcare as the US. So you can see the United States is way up there on the top in the green, and comparable countries are, much less than that. I've had the privilege of being in Sweden, who ranks, what is that, like 5th on the list? And they have a completely different care model. They really have patient-centered care. They have family-centered care. The family comes in the morning, they have a breakfast buffet in the hallway on the med-surg units, and the family comes in and makes what they call fika. And they make the meals for their own family members and go in and help feed with all their family members and spend the whole day in the hospital with them. So completely different care models. And I think that's what we need for this next normal, is to look at what's working well in other countries, other areas, and what can we adopt. Also, I was talking about that the US has fewer practicing physicians, which is interesting that our healthcare is more expensive, but we have fewer physicians, 1,000 people per most comparable countries as well. So you can see Austria, Switzerland, Germany, Sweden, all of those ahead of us of having more physicians per 1,000 people. And there was one more. But then I thought it was interesting that we actually we're slightly more licensed RNs per 1,000 people relative compared to other countries. So that was an interesting factoid to me that I thought I'd share with you. Okay, sorry, I'm having a difficult time with slides. Also looking at the COVID impact, what has it been for 2021, right? Looking at just June to August of 2021, we've spent $5.7 billion on hospitalization. And over 280,000 COVID-19 hospitalizations could have been prevented with just the vaccine. So I don't know about you, but I think a lot of nurses are really feeling the frustration of there were so many easy things that we could have done, like vaccinations, masks, social distancing, all of those things that we know as caregivers could have easily been achieved to prevent this from ever happening. So here we go. In getting ready for this presentation, I follow Rose Sherman on her blog. She has an emerging leader blog through AONL that represents AONL. And one of her latest posts was criticizing when you're not in the arena. And she was talking about, she had met with a CNO who had left an organization and was looking back at the organization and saying how frustrated she was that they weren't following some of the patterns that she had achieved while she was there as a CNO. And Rose eloquently put this list here together. And it resonated, every single one of them resonated with my work as a chief nursing officer at Cedars, that I arrive in the morning and there's 30 patients in the ED and there's no beds in the facility or even in the immediate area. We're holding 42 patients in our ED right now today, and there's no beds in the hospital. They're all full. And I've heard of other organizations, particularly like the YouTube that's out there from Louisiana, where the chief medical officer is saying they closed 200 beds because they simply don't have healthcare workers. So I think even, number two also struck me as you think you successfully negotiated a travel contract to supplement your core staffing and then learn that there's no backfill from any agencies and there's many vacancies. I had paid premium rates for travel nurses to come in, particularly for our L&Ds. We deliver about 6,000 babies a year, which is amazing, and really difficult to recruit that specialty labor and delivery nurse. Paid top dollar, had people come in, they spent 2 days in orientation and left and got a higher pay somewhere else. And there's no retribution from the travel company or from us because you don't want to be blacklisted and not have people want to come to your organization in the first place. So there's really key things. And I think one of the things that made me the saddest was you meet with your group of new graduate resident nurses and they no longer see hospital nursing as a viable career, the last one. And I can tell you that people talk about people retiring now and the retirement gap and how significant that is, but that's not what concerns me for sure, but that's not what keeps me up at night. What keeps me up at night is a few months back, and I might have even shared this with you all last time, is in 1 week, in one pay period, 2-week time frame, I received 10 resignations from people who were in their 30s and 40s, who were somewhere new to nursing or had been 5 to 7 years in nursing and left the profession altogether. So again, that's my burning platform on why we need to think of a completely different models, what's out there, what can help us, what technology can help us. So here's my next normal leadership toolkit so far. I think advocacy is huge. I think mentoring will be the name of the game. Succession planning has to be in place, and then a really robust shared governance structure, shared decision-making with a clinical point of care so that they stay in our organizations and don't leave with the travel companies and chase the money, as they say. So advocacy for me starts with belong to a professional organization. And yes, we're a little skewed. Me, Rob, and Chris, we're all in ANA California on the board. So I thought I'd put a plug in for us, but it's really saved my professional career to belong to a professional organization. I didn't understand the significance previously. There's so many resources available to you. There's major national studies going on with data that tells you things that you need for your papers and to just justify your staffing needs and different things. So lots of resources, lots of networking at both the national level. I love that ANA, the American Nursing Association, was created all the way back in 1910, and just see them in action and being at the White House and lobbying for the needs that we have in nursing. And then us at a state level, ANA California has gotten much stronger, as have many of the state organizations. You can really rely on them to be able to, if you have a passion about a particular topic, there's toolkits and templates and things that you can talk to your representatives and senators about. So really, I encourage all of you to join your professional organizations. And so nursing is ranked the most honest and ethical once again. And what are we going to do with that? I think this is the time to, again, pull the forces together, really talk to the legislators, the people in Washington, D.C. who are figuring out funding for the next year, 2 or 3. And what can we do to lobby to be able to protect care models and staffing models that we need? And this is just a fun picture of us in the state of California at the legislature. And I can't wait till we can go back in person. This is obviously in 2019 when we didn't have to wear a mask. And just bringing people together, showing them what it looks like to get involved in the government is really big and a passion of mine. My favorite part of the toolkit is figuring out models. My DNP taught me well to use different models. And one of my very favorite is James Coots and Posner out of Santa Clara University and the Leadership Challenge. I've used this book many times with my nurse managers in development classes. They have a pre and post survey, so you get some good data around that. They propose a model that resonates with me very directly. I don't know who else has had the opportunity to use this, but my favorite piece of this, the 5 practices of exemplary leadership, are modeled the way. I think when we show up to work as leaders, remember those days, even as a charge nurse, if the charge nurse shows up to the unit and they're good to go and they might be understaffed, but they're make a team and we're going to make it through the night, everything goes smoothly. But if the charge nurse shows up and is scared and talking about how many sick calls they've had and things aren't going to go, the ship's going down, the ship pretty much does go down that night. So I think modeling the way and teaching our leaders all the way from the point of care to the boardroom that what they do, say, and how they show up really matters. And then inspire a shared vision is so important. I think a lot of times there's a disconnect between strategic plans of the organization, whatever organization you're in, and the point of care clinician or the GIMBA. And I think it's our job as leaders to really inspire that shared vision, take that org chart, strategic plan, make it a nursing strategic plan, make it a unit specific strategic plan, so that we're all working with falls with injury, we're all decreasing, infection rates, we're all beating to the same drum. And then my favorite, well, okay, they're all my favorite, but one more of my favorites is challenge the process. I believe that we have to, educate ourselves so that we can go in, and that's what I'm doing today. I feel like we need to challenge this process, to challenge the old way of being in nursing and look to new ways and new models and new care delivery, and enable others to act. And that's that mentoring succession planning piece for me. We have to build strong teams. We can't be the only person. We can't run the whole ship and that's it. We have to figure out ways like shared governance structures and some of the articles that we write and everything to be able to enable our others to act. And lastly, and I think most importantly, is encouraging the heart. So creating that just culture, that non-punitive culture. I brought in the just culture algorithm to Cedars. They were using pieces of it, but we've been exploring it on a broader level. And it really resonates with people. It's like nobody shows up to work to make a mistake or make an error, but errors happen, and it's part of the human process, right? And so what do you do to mitigate that and actually have people talk about the errors that they make so that you can change the processes in the organization and make it so that they can show up every day for a safe environment to practice in. So my very favorite model of leadership. And then you can't talk about leadership without acknowledging Brene Brown and her ability to help us embrace vulnerability. I love this quote: vulnerability is the birthplace of innovation, creativity, and change. And that so resonates with me. Watch her YouTubes, watch her TED Talks. She took the position of you have to be strong all the time, everything in leadership needs to be strong, to like, no, it's okay to just fall down and cry and be with your people and be real. So I highly encourage people to explore her TED Talks. And then it wouldn't be a leadership toolkit without talking about caring science. For me, I'm a Cara Tusk coach with Dr. Jean Watson. She's a PhD out of the University of Colorado. Got to spend the start of this week. She came to Cedars and spent a couple of days. We've adopted her as our nurse theorist. And she is a philosopher by her bachelor's level, and then moved on to really being one of our great nurse theorists of our times. And she talks about, caring science and how do we develop a caring science within our organizations. And that it's really a transdisciplinary, I love that transdisciplinary across all approach that incorporates the art. And she brings back the art of nursing and the science of nursing and includes concepts from the field of philosophy, ethics, I like ecology. We were just talking about our children in the state of California and how we, Nurses for Healthcare Alliance, I can't remember the exact title of it, but they do such a great job on lobbying for the protection of our children in the state of California against cancer-causing agents. So really looking at that mind, body, spirit, medicine connection. And then her quote, "We are the light in the institutional darkness, and in this model of caring science, we get to return to the light of our humanity." And I've used this model with many nurses, and it really resonates. It's not for everybody. Every model is not for everybody, but it really resonates with many of the sacredness of the work of nursing and how to bring that back to what we're experiencing today. So next steps, developing people. A huge, I think huge to all of us is how do we develop our staff? How do we look at that associate degree level nurse and what do we do with that? how do we help develop the associate to the BSN level? We've talked about that the magnet requirements, which a lot of people misunderstood, was a magnet requirement to have 80% BSN. I love Chris, how during our listening tour, you were able like, that is not a, Chris is a magnet appraiser. She's like, that is not a magnet rule. That's what somebody who's created from it. But many institutions or organizations, I should say, really came to believe that they had to have 80% baccalaureate prepared nurses only. And it's really not that. It's like, how are you getting to the goal of that? So, you know, for example, at Sears, we're at, I think it's up to like 96% baccalaureate prepared nurses. We have some room, that wiggle room, where we can make some associate degree movement. And so it's been difficult though for our nurse managers, you know, because they've kind of gotten ingrained with the HR partners to only hire bachelor's prepared and above. And so we're actually developing a program where we can hire associate degree nurses, bring them in, fulfill the needs of the organization, and help coach them up. The same thing goes for the LVN. We're looking at models around the LVN. So I'd like to hear if anybody else has any experience with that. And maximizing the nursing assistant role, I think, is a big deal for us right now during this time frame. And then the student nurses that we have, how do we bring them in as student nurses and elevate their roles? The BRN allowed us to during COVID, and we did. It was very successful to be able to see the student nurses come in on, our travel company was actually able to bring them in through the travel company, onboard them, prepare them, and then we had them doing higher functioning roles. So it was, again, we need to think out of the box. So there's an X normal in my language for education. I think we need to look at student loan forgiveness for our baccalaureate prepared and even some of our PhD, all the way to PhD level. I think that would help a lot. Again, our ADN hiring practices that support the BSN, and then streamlining the BRN licensing. I know Robin's working with this for quicker entry into practice, and shortening the timelines for our new nurse residency programs. You know, we've developed these beautiful, robust year-long residency programs. Is that really the best still solution? So we're already looking at compressing ours to 6 months and giving them a broader mentoring platform after that. But we perhaps might not have the time and the luxury to be able to give them a year anymore of true residency as they become our new really substantial pipeline. It's hard to find an experienced RN right now. So our new hires are our new graduate nurses. And then addressing more practice issues around simulation and death and dying scenarios. Particularly during COVID, we've seen so much death and dying. I don't think any scenarios would have gotten us ready for that. But I do think, from Robin and I have talked about from the nursing perspective, that it would be good to have those real life actor simulations where they could actually partake in a person getting recently diagnosed or holding the hands of a person who's dying of COVID, so that they're not coming into the unit and the first time they're having to deal with death and dying is the time that they're on the unit with a real patient. And then practice transition programs from community settings. So if we have, when we had all the nurses, sorry, I keep moving ahead too far. And when we had all the nurses in a plethora of nurses, and there was many that couldn't get jobs in the inpatient sector, even though they wanted that, and they did go to community settings and SNFs. How do we help them and create true programs so that they can come in, because they're kind of our lost generation where they can't go into a new nurse residency program anymore, and they can't be hired for an experienced RN. So how do we rethink that role? So my other next normal is care delivery models. Again, increasing the new nurse residency, looking at the student nurses and their roles in that, decreasing the charting burden in Epic or Cerner or whichever electronic platform you have. I went to the Epic UGM in Wisconsin a month ago, and there's many organizations who during COVID, we went to crisis charting, and we were able to take those 85 initial assessment questions down to 23 clicks. Why can't we sustain that model? So they're looking at it right now. How can we go back to like crisis charting or charting by exception? Remember those days when we used to do that? Becomes again the next normal. And medication administration, maybe we need to blow it up. Do we need to think about, can the pharmacists on some level give our medications for us, so that maybe we have different models of care where there's one RN for 15 patients that has multiple support factors around him or her. During COVID, we had our physical therapy walk all of our patients. They came out in teams, and they didn't just treat it as physical therapists, but truly as ambulatory teams. And they came out on the units and just did walking rounds with all the patients. huge offload to the nursing and the nursing assistants. My last next normal is technology. This is the one I think that we really need to take and embrace. Looking at AI, I talked to a company just last week about how they're using AI. They've looked at like 70,000 different patients and predicted their moves using predictive analytics and AI and machine learning and all of it put together to see their shoulder movement before they even try to get out of bed. So instead of waiting for the bed alarm to go off, which is way too late, that person is already going to fall. You actually can tell by the shoulder movement. The AI alerts the nurse on the Volt phone, and the patient stays in bed. So that's just one piece of the tip of the iceberg. There's so many other ways to look at it. I'll show you a little bit about robotics in a few slides, what we've done at Cedars. And then telepresence. There's companies looking at how do we have a television screen in the room, not just for telemedicine, but for true RN telepresence, right? And so the RN is in the screen. They can do admission documentation, discharge documentation. They can even do case management, which is, I don't know about any of you, but we're having a difficult time finding a strong enough, big enough case management team. So huge, vital piece that would solve for. And then the big data accountabilities, I think we need to look into, and we're all aware of the privacy issues. And so from the virtual platforms with the technology, I think we've loved Zoom and all the different platforms. Like Robin said, it's great for hybrid model, but what do we do in the future? How does that work? We started our shared leadership council structure, and we've all been virtual for the last 4 months, and they're just begging me, like, can we please come back in the room and be together? We want to see each other. I got to have a retreat on Tuesday for my nurse managers, and it was the first time since I've been at Cedars, so 18 months, it was the first time we actually all got to be in one room together. Of course, mask, socially distanced, hand gelled, but the first time in a year and a half that we got to be together, and people were just ecstatic to be together again. So we have to figure out those platforms, right? So now I'd like to just talk to you about a case study from Cedars and some of the things that we've done. We're just in the beginning of it all, as you are. So just wanted to show you a few things. We did create a capacity command center for the whole hospital and system to be able to really look at how is patient flow moving through not just our hospitals, but the other 4 hospitals that we have. That's helped a lot. We reinstituted all the daily huddles to increase transparency and communication. So we have a 8:30 a.m. surgical huddle. We have an 8:45 where I bring in the executive directors of nursing and staffing, and we just looked for escalation patterns. And then we have a 9 a.m. where the whole organization gets together. So about 300 people on a Microsoft Teams get together for an organizational huddle, again, for escalations. And then we instituted an ICU staffing. We were having problems there was so much movement during COVID with the ICUs moving to the PACUs, moving back to the ICUs, that we actually needed to create a huddle to see where was all the staff going with all their skill sets. So they have one at 4 p.m. and one again at 4 a.m. And then I think one thing that really worked well was having a 9 p.m. for night shift huddle. I was a night shift nurse for 10 years in the ICU, and it's a really lonely place. So this brings them together at 9 p.m. so that they can, again, escalate any issues or needs before it's 2 a.m. and it's kind of out of control already. Oops, sorry. So the next normal is really increase that innovation solution from the point of care. So with our clinicians, again, just shared leadership councils are a great way to do that. In only the 4 months that we've restructured our shared governance into a shared leadership model, we've already had 146 care forms, they call them, they're the request forms, come in, and they're solving problems from the point of care. So they've solved things like construction happened and our lactation room got wiped out, and so they put in for a new lactation room, and we were able to achieve that. They wanted Starbucks 24/7, and we were able to achieve that. Nice low-hanging fruit that you can solve for the point of care to improve their just practice environment and their, joy at work when they can get a cup of coffee at 2 a.m., right? And linen hampers and all kinds of different things. But I think having that closed loop communication with the people that are doing the work at the GIMBA, at the point of GIMBA, as Lean says, is so vital to what we're going to create in this next normal. This is the accountability structure model that we use for our shared decision making. It's really, we literally hold it up all the time and can see, this is a Haig, Heitman, and George model, but can see that on the left side is the clinical practice accountabilities of standards of practice and care delivery model and professional development and quality. And then on the right side of the model is the management accountabilities of finding enough staff, hiring all those travelers you need, monitoring those staffing patterns, and building true structure, and most importantly, developing significant rewards and recognition programs. So robotic solutions, this is Moxie. She, well, I guess I shouldn't call her she because it is non-gendered robot, but it does amazing things. We're piloting 2 right now on our inpatient units. And if you can see on the bottom, that's her front cavity opens up and can actually hold like 2 Alaris pumps. And the back has a contaminated specimen holder. If you want to send specimens down, you can send them down. You badge in and out. So she goes to wherever and picks it up and delivers it back to the unit, and you can badge in to pick up your medications, narcotics, supplies, whatever it is. So we're just starting our pilot right now. They actually did all the mapping around the whole entire hospital, so the robot could function independently, but just amazing things that we're able to do. And that on the left-hand side there, you can see Melanie getting her 2 first Alaris pumps to her unit where she's had difficulty getting them in a timely manner, and Moxie delivered it in 20 minutes. So it was great. So just some ideas. We're looking at, we developed our mentoring, and there's many platforms of mentoring. This one is called, I think it's funny, the robot's called Moxie, and this is called Life Moxie. But ACNL uses it, ANA California uses it. It's just one electronic tool. I'm not promoting this particular tool, but anything that you can do to connect staff with other staff, and even outside of nursing, and get mentoring in business, with the business partners and all kinds of different things. So I think it's really vital that we connect people so that they can have a defined course and some real help in developing themselves, particularly post-COVID. And you couldn't have the next normal without increased recognition. So on the left-hand side there is where with our RN-MD collaborative, the physicians round with the nurses and appreciate the nurses and the other clinicians at the bedside. And then up in the right side, you can see it's Physician Appreciation Day, and the nursing units build these great posters for their physicians. This is just the start of it. And then they have this whole gift box that they give them filled with love and love notes, and really appreciate who they are. They have the physician come to the huddle, or the physician team, depending, and they read all the posters to them and really just appreciate each other. And that's one of the things I've really enjoyed, is the collaboration that we've seen during COVID, and even as we're coming out of it. We were able, being the Caritas coach and Gene Watson's Caring Science, we were able to develop meditation lounges. We used our affiliation there and used some patterns that had worked in other facilities. The staff created them. It was amazing to see what they created in every unit. Everyone's slightly different, but it gives them a break from the day, and it's for all disciplines can use the meditation lounge. So it's just a wonderful time to get away, and much needed during COVID. And we were able to get ours funded by our donors. So I think when we always worry and think too much about money, there's lots of people who want to figure out how to provide some solutions for healthcare and for nursing. And so let them, embrace them, look forward to it. And I spoke a little bit last time about letting go, but we've continued our letting go ceremonies, where we really needed to look and first acknowledge what we had been through to move to the next level. We used Rose Sherman, again, just love her writing and the things that she puts together, but trauma-informed care of the nurse leader. So we worked with our organizational development team, our spiritual care team. We created a safe space, found a space off campus, laid ground rules for the afternoon. It was only about 3 hours, and we brought together nurse managers and nurse leaders, and then they're cascading it down to the staff. We had things like invisible ink that they would write down somebody who had perhaps died of COVID, somebody they lost in their family, something they needed to let go of and let rest and let be, on invisible ink paper, and then they put it in a big bowl. And we made a big ceremony where everybody was around them to support them, and they'd kind of wash whatever that was away. It's so beautiful. And just a quiet circle time for sharing, where we went through the 9 different questions that were proposed on the trauma-informed care, and really talked about how do we want to come out of COVID? What do we want to be remembered for? And then we did a super fun positive energy. We have Liv, she's a specialist in positive energy aerobics. So for 20 minutes, she does affirmations with you as you do aerobics, and has all these power poses like the power of woman pose that you do as well, to kind of raise the energy back up for the end of the day. And then everyone's ended the day with an angel card, and it's just a card that has one word on it, and they drew their own and then reflected on what that meant for them for the day. So it was just a beautiful time to spend together, just to define and carve out some time, like we need to let this go and lay this down. And how do we go about doing that? We're actually writing an article to publish on this soon, so I can't wait for that to come out to help others. And that's just a slight piece of it. That's with one of the groups. So we use the Caritas circle. So, really laying down things on the ground. We had chairs all around, but this is right after we were doing our aerobics, and have candles, and we didn't have tissue there, but have lots of tissue because there's lots of tears to be shed, and just honest sharing that really happened with people. So saw that totally improved the teamwork of the team after we did these ceremonies. So that's all I have for you. And my question is, what's your next normal?